cancer.
Right.
Therefore, if you're a black man over the age of 45 and you're having urinary symptoms,
Right.
you should see your doctor with a view to being investigated. The symptoms of prostate cancer.
Right. Can you continue, Professor Frank?
Yes, yeah, I will do. I'm sorry, I'm getting like a feedback. So I say something, and then I hear it back. So I don't know whether you're hearing the original or whether you're hearing the playback. But anyway, I'll carry on.
Yes.
So if you have urinary symptoms, such as I mentioned previously, slow flow, going frequently, getting up at night, and so on, then you should go and see your doctor.
Right.
And one of the things the doctor will do is to check your prostate gland, which is done by passing a finger into the back passage, and also sending you to have a PSA blood test, a prostate-specific antigen blood test.
Right.
Now, if this blood test is higher than it should be, that is an indication for further investigation, such as by a urologist. So importantly, just to recap, you don't have to have any symptoms to have prostate cancer. And the symptoms, if you do have, are urinary symptoms, which overlap with the same symptoms of an ordinary benign swelling of the prostate. Now, most men over the age of 50 will have urinary symptoms, but only a percentage of them will those symptoms turn out to be due to prostate cancer.
Right. Why are black men susceptible to prostate cancer?
So we don't know the answer to that question. That is the subject of much ongoing research in America and in several West African countries. There are big research collaborations looking into this very question. Genetic samples, blood, saliva samples are being analyzed in many thousands of men and compared with non-black men to see if we can find out what is it about the African diaspora that puts you at an increased risk of developing prostate cancer.
Okay, thank you very much for that, Professor Frank. We'll still bring you back in. The next person I have here is another urologist. Professor Frank has been talking from the perspective of the African diaspora. Let's see whether she has a totally different view of what Professor Frank has just said. The next speaker, she's a lecturer in the Department of Surgery, College of Medicine of the Lagos State University. She's an honorary consultant urologist with the Lagos State University Teaching Hospital in Nigeria. She practices as a general urologist with broad-based clinical and surgical experience in most urologic cases, a fellow of the West African College of Surgeons, and she's the first female urologist we would ever have in Nigeria. Welcome, Dr. Abimbola Abolariwa.
Thank you very much.
Okay. As a female urologist, let me first of all ask you, and you practice in Nigeria, a place entrenched in culture and traditional values. What are the challenges you face from your patients? Of course, the majority will be males, if nothing else. So what are the challenges you actually face dealing with your patients?
Challenges in the sense that acceptance of treatment by a woman. Is that what you mean?
Yes.
Well, I don't think I face many challenges with that aspect, because even if Nigeria is a cultural society, women have always had their cultural place in Nigeria. Women have always been known to work culturally and traditionally, particularly the Yoruba women. Yoruba women have always traded. They have always been educated alongside with the men. So it's not an issue for me down south in Lagos.
Okay. Is it because maybe you're in Lagos cosmopolitan area? So. Is that
Lagos is cosmopolitan, so I think so.
Okay.
I think that is why I have it very easy. I may have some colleagues up north that are having some challenges, but generally relating with other urologists from other parts of the country, They
Right.
don't seem to have a problem with a female being in urology. And as we speak, we have 5 female urologists in the country.
All right.
And 2 others in training.
Now, so Professor Frank said something in relation to African diaspora men. Do you share that view?
I share the view. We noticed that most of the patients we see at the hospitals have advanced disease. And the reason is that they don't have the awareness that this is a disease that could actually be screened and detected early. And that's because most of the healthcare in Nigeria is out of pocket, usually not backed by a health insurance scheme. Maybe the private health management organizations, which are based on those that earn a salary. But basically, it's out of pocket. And so what brings a patient to hospital are complaints of usually pain or discomfort.
Right.
And by that time, the patient probably has, some advanced disease. So it's a case of not coming to the hospital because they just feel fine. And majority of prostate cancers, particularly in the early stage, are asymptomatic.
Right. There's also one other issue because at times I'll be creating scenarios here, and that's actually based on discussions I've had with some men who do not want their faces to be shown or who do not want to ask the direct questions. How do you cope with one of, in our culture, in the African culture, there's this issue about social status, chief,
Okay.
engineer, whatever comes to you, Mr. Big Man, and you're trying to tell him, go for the PSA test. And he's referring to his ancestors. My father lived beyond 80, 90, or 100 and whatever. I don't feel the reason why I should go for a test. How do you encourage people like that to go for the PSA test?
The problem you see, this scenario you described is quite common. But the issue is that it's because they see doctors as different from them. You need to be able to communicate with your patients. And that's one good thing that a Nigerian doctor has an advantage with. Communication. You come down to the level of the patient. You make them see it. In fact, you just may have to refer to these issues they have with something that they are used to. Like now, I tell my patients, do you have a family history of prostate cancer? Very difficult to attain because they'll just tell you, maybe in Yoruba, Ikulopa Baba.
Exactly.
Death took away the father.
Yeah.
So you will have to speak with them in the language they understand, not necessarily the language. Even if it's English you're using, you need to come down to their level. You need to gain their trust. And then when you tell them to do a PSA, they happily do it. Now, I want to tell you something you may not know. Nigerian patients love to do tests. They are so quick, and if you tell them, don't worry, examine them, they'll say, doctor, any tests, any drugs. So they are willing. And, against the popular opinion that men are not interested in their health, a lot of men are coming forward now. They want to do tests. So many of them would even come to you without seeing you with a big envelope full of test results. So many unnecessary ones, though. So it's when I hear people say people don't want to do tests, I don't know. Nigerians want to do tests. In fact, they even trust the laboratories more than the doctors. So they already have done their tests before coming to meet you. I have patients that have done PSA in 4 centers before coming to meet me. And you're like, okay, which one do you pick? Because the assays are so different. And also, test is not an issue for a typical Nigerian patient. In fact, they don't believe a consultation is complete without having tests done.
But the thing is, it's one thing to have the test. It's another thing to take it forward. Maybe you've detected something, cancerous cells. Do they come back to see you, or that's the end of it?
No, they usually would come back. Once they've seen a doctor and they've done tests, they want you to interpret it. They always will want to come back to whoever sends them to do those tests. The issue now is who sends them to do it. A general practitioner, a healthcare worker that is not a medical doctor. Whatever the case, they need to get to see a urologist. The PSA is very abnormal. And beyond the PSA, you also have to do a digital rectal examination. If not, your assessment for the prostate is not complete. So usually they would come back to see a doctor. Now, getting to see a urologist may be the challenge because there are not many urologists in the country. We are still not up to 200. That's where the challenge is. And that's why we try to train even the doctors at the primary healthcare level and the secondary healthcare level on how to assess a patient for prostate cancer so that those that need further assessment like a biopsy are referred to the teaching hospitals or tertiary centers where you may find a urologist.
Right.
So now we try to teach other doctors so that they don't leave these patients at their level, progressing with a possible cancer.
Right. So what would you say is a normal PSA level?
Well, that's another controversy. Studies that were done, long-term studies that were done in the Western world, particularly in the US, gave a range of 0 to 4 as normal, 0 to 4 nanograms per mil as normal. But we had a study in Lagos. I would like to state that Lagos State is one of the states, or if not, maybe the only state in Nigeria that was doing routine prostate cancer screening at the local government levels. And this had been going on continuously for about 11 years. We just had a little break and we'll probably go back to it after the COVID pandemic. And we were doing annual screenings. We may pick about 3-4 local governments and screen. So we pulled all this data and were able to see that this normal range of 0 to 4 may not be applicable to the Black population, particularly using Lagos as a sample. We found out that because we have the normal range 0 to 4, then we have PSA based on age range 40 to 49, 50 to 59, because the older a patient gets, the likelihood that the PSA will be higher. So if I see a PSA of 7 in an 80-year-old man, I will not panic. But if I see a PSA of 7 nanograms per mil in a 40-year-old man, I may be pushed to assessing further to see whether there is a risk of prostate cancer. So that study we did in Nigeria, in Lagos, showed that the PSA range for 40 to 49 was actually about 4.89, 50 to 59 was about 6, and then even 70 to 80 was about 8 nanograms per mil. So our PSA values for patients that we are not likely to have cancer,
right,
fit into this strict criteria that we did, were actually higher than the reference ranges that we got for the from the Western world. And maybe because the Black prostate is bigger in size, so there's more PSA to be elaborated by the prostate cells. Maybe, but we don't know the reason why we likely have a higher PSA. So if I see a patient with a PSA of 10, I won't conclude that he's likely cancer until proven otherwise. I may take it that maybe he has inflammation, like Professor Frank said, or maybe it's a lab sensitivity in the assays or something, but I won't jump on prostate cancer, particularly if the examination of the prostate is normal. Because our reference range, even for our study in Lagos, showed that our baseline PSA is a bit higher than the references in the textbooks.
Right. I want to, part of what RAM focuses on is to demystify some taboos. And one of them is prostate cancer contagious?
It's not.
Good.
It's not contagious. We get this question all the time from the wives. Is it contagious? And we say no.
Okay. The next question I have for you is that you have to be of a certain age. You have to be in your 70s before you can develop prostate cancer.
No, you don't have to be. There are certain risk factors for developing prostate cancer that are known and documented. And these risk factors that are strongest are actually unmodifiable. Race is one of them. The Black race have likely chances of developing prostate cancer and the more severe forms. Number 2, increasing age. And then number 3, family history. If you have a first-degree relative, that's a brother or a father, who has had prostate cancer, the likelihood of a man developing it is as high as 50%. So these 3 factors are unmodifiable. It has nothing to do with what you eat or what you drink or whether you exercise. Those other factors have to do with general well-being. But those 3 I mentioned are unmodifiable. And so we see some patients that have prostate cancer even in their 40s. We have diagnosed prostate cancer in some men in 30s. So it's not a given rule that a man must be in his 70s to develop prostate cancer. We are seeing prostate cancer in earlier, younger age groups. And then we've seen people get to 90, 100 and they don't have prostate cancer. So you must assess each patient individually.
Right.
It's not a one rule fits all.
Okay. We're still going to come back to you and Professor Frank when we talk about whether there is something called taking preventative measures in terms of what do we eat and then what do we do to prevent prostate cancer. So we'll still come back to that. Now, I want to bring in a couple. The couple, Mr. and Mrs. Russell. They're going to share their personal experience on prostate cancer with us. So, Mr. Russell, are you there to share your experience? Okay. Can you hear us, Mr. Russell? You can unmute yourself. Yes.
Okay. Yes, I can hear you.
Okay, fine. Mr. Russell, welcome. And once again, thank you so much for coming up here to share your personal experience with us. It's not really, in quotes, a black thing, you know,
No.
talk about your personal, very personal department. And so, but then again, it's going to encourage a lot of people listening here today. So we do appreciate you coming on board, even showing your face. Mr.
That's
Russell,
right.
you're from the Afro-Caribbean community.
Yes.
And how old were you when you discovered you had prostate cancer?
I was diagnosed when I was about 63 years old.
63 years old.
Yes.
What were the signs? What were you experiencing before you realized that, or you came to the conclusion you had to go and see a doctor?
Well, there was not any signs as such. I'd had one biopsy. Well, let me start from the beginning. I used to live in Europe, in
Right.
Germany, actually. And in Germany, every year, they would screen the prostate, do a prostate test from the age of 45,
Right.
like the professor actually said earlier. That was in Germany. And when I transferred to UK, and then I was in the UK for about 3 years and nothing had happened. My GP didn't give me an invitation to come and have a prostate test
Right.
within this time. So I went and spoke to my GP and asked him why. And he said he don't generally do that. But he said if I wanted to have a test, then he would facilitate it.
Right.
And that's what he did. And he actually, my PSA was quite normal to a certain extent, but he did a biopsy. They did a biopsy, funny enough, and the biopsy was not satisfactory. It said on certain parts of my prostate, although I had no symptoms, I hadn't felt any symptoms,
Right.
there was some kind of, how shall I say, something was not quite right, the professor had said, who conducted the biopsy. So he said, we'd need to do a second biopsy, but I wasn't very happy with that. So I decided that I would do maybe a biopsy later, but and then I went to a different hospital, to tell you the truth, because some things had happened in that particular hospital which I wasn't really satisfied with. My documents were lost, etc., things like that. It wasn't like a physical thing. The doctors had done their job, but unfortunately the administration hadn't. And they lost all my papers on all my documents.
Right.
And that's why I decided to change to a different hospital. And when I did that, they then conducted another biopsy and said it looked as though I among other things, they'd conducted also other investigations and said, we'll do one more biopsy just to see, to make sure that we can give you the all clear, because up until that point, everything was all right.
Yes.
And when the result of that biopsy, the last biopsy came, it actually said there was some sign that a very minute cancer was developing in my prostate.
So did
I
you
was not very happy.
Right. So did you at that point think, oh my goodness, this is a death sentence?
Yes, absolutely. Because I went happily to this appointment with the doctor. It was a beautifully sunny day, I'll tell you, like today here in London. And next thing you know, I expected a different result. I thought he's going to give me the all clear, but he didn't. He said, no, we can't give you the all clear because we found something in your prostate. And that was totally disastrous for me. and for my wife, actually.
How did you convey the message to your wife?
I remember she was actually with me, and as a result of hearing the result of this biopsy,
Right.
I think I switched off to such an extent that I didn't hear half of what the doctor was trying to say to me. And that was good that my wife was there to actually hear the conversation and correct me on certain facts which he'd actually told me at that particular time.
Right.
Because I was in a different world when I heard the result of the biopsy. I was not very happy, I'll tell you.
Right.
Yeah.
So how long ago was that?
That is some 5 years ago when this happened.
Okay.
No, it's actually longer. It's like 7 years ago because they told me that it was only a very minute, cancer, which was hardly to be seen even.
Yes.
I thought, and they said one of the options which I had was to wait and see if it was going to get worse, or maybe, and I thought I could use herbal methods to get rid of this cancer.
Right.
So I embarked on a journey with a herbalist to try to use herbal cures which I saw as cures. Not that I was recommended by the doctor, but I still took the medicine of, well, I wasn't being treated at all at that stage. I said, and the hospital which had done the biopsy, they have this policy where they said, watch and wait for a certain time to see how the cancer is developing, because it doesn't develop very fast normally. It takes quite a while.
Right.
Especially, it depends on the individual, obviously. But in my case, I waited for 2 years before my PSA got so high that my consultant said to me, we need to treat you. Now, we need to start treatment. But up until that point, it was my decision whether I would get the treatment or not.
Okay. Now, that must have been 7, 8 years ago. So you're still very much with us?
Yes.
And are you still receiving treatment?
No, I opted for radiotherapy treatment. You know, it was very difficult for me to make a choice.
Right.
Because my consultant also wanted me to have the brachytherapy, whereby they put something like rice seeds in your prostate.
Right.
And it's radioactive.
Right.
And that kills off the cancer.
Okay.
Yeah.
We're glad that you're still here with us. And I know that it's still going to be for a very long time.
I hope so.
May I speak with Mrs. Russell, please?
Certainly.
Oh, you can do if I get into the camera. Yeah. Let's see. Yes.
Hello, Mrs. Russell.
Hello. I don't know why, but I can't.
Yeah, I can see you now. Yes. We can all see you now. Thank you so much for coming. This is something that a lot of women too will shy away from. And we do appreciate the fact that you stood by your husband and you're still standing there, and obviously a good support system for him. When he came home, oh no, you were together anyway, and you heard the bad news. How did you take it?
I just saw that it's clearly the change is going to happen, but my main thing was support, really. Because if he's going through a bad time, there's, you know, the only thing I can do is support. And I think, as my husband mentioned, going to all the hospital visits, or as many as I could make, is a good way, because there are some ways that some things he doesn't hear because of the bad news and the impact on him. But I just saw that as much as possible, which, you know, all the hospital visits that I'm able to go to, I would go. And that was also taking me through the journey as well. So from beginning to the end, I was there.
Right. So obviously you were also getting support in terms of what to expect, and that there wouldn't be any activity for a long while. And how did you take that? How did you take that on board?
When you say activity, you mean sexual
In terms of
activity?
sexual activity, yes.
Yes. Now, I'm from a health and social care background, and therefore, that to me, I have some knowledge, and that wouldn't to me be uppermost in my mind. To me, that was a small thing compared to what he was going through.
Right.
So I wouldn't, certainly wouldn't have made any form of demands,
Right.
because that would just be selfish and unfair. So
thank heavens.
So you know, if I know that is an important thing to him, and if things are not working, it's not going to benefit anybody for me getting upset or even focusing on that, really.
Right.
So I didn't, and it didn't bother me.
So the focus was just to make sure that he was healthy.
Yes.
For the right treatment.
Yes. Yes.
Very interesting. Thank you so much for that. We'll probably come back to you because some people might have questions for both of you. So thanks for sharing the story with us. The next person we have is Mr. Emiola Odeumi. I interviewed Mr. Emiola about 6 years ago. He's also another prostate cancer survivor. And when I interviewed him, this was face-to-face, the usual format for our RAM discussions. And all the men who were there, when I asked the question, does anybody know what PSA test is? It was so strange. It was only Mr. Emiola who did. Jason, who is a representative of Prostate Cancer UK, and of course, Professor Frank was with us. The other men were like, prostate cancer, that's not my portion. And I'm like, whose portion is it anyway? And some people were saying, no, it happens to all people. Is it really a black thing? No, it affects Caucasians. It's got nothing to do with black people. But now we're talking about the statistics. 1 in 4 black men will have prostate cancer. So, Mr. Emiola, thank you for coming back again to share with us your experience. How did you find out that you had prostate cancer?
Good evening, everyone. We've done this over the years, and by 2007, are you hearing me?
Yes.
Am I clear?
Yes.
Yeah.
Yes.
About 2007, my brother, my immediate senior brother, had an operation, and we were told to actually get some drugs in England. And then my wife, being a pharmacist, said, this is cancer drug. Well, we have lost some people in the family, and you know, Yorubas, they are very secretive about actually what is wrong with them. And from the queue that it's my brother, the doctor, well, we keep on buying the drug, which is about 50,000 naira at that time. And when I now visited home, 2007, 2008, the doctor said, oh, it has already spread. What he needs is palliative. That shows it will not last maybe a few months. Everywhere it's already gone. And immediately I got back to England, I had to tell my wife, what do we do? Then I went to see my GP, told him the story, and then I went for my PSA. So since that 2007, I've been checking on myself every year to do my PSA. But unfortunately for me, 2015, almost about 65, my PSA went up for the first time. And the doctor actually referred me to see the urologist and blah, 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 blah. We did the PSA biopsy. I keep on all the tests. And there was at a time, the PSA went up further, and then went to see, I had an appointment by that time. And what I had was, do we manage it? It could take 5 to 10 years. It might not grow, this and that and that. So I came back to Nigeria. By that 2015 October, I did my test in Nigeria, and the thing went bizarre. From 9 point something, then went to 13, 13 went to 19. So I quickly changed my ticket. I came back to England. So I had to go and see my GP, the urologist, and everything. There and then, we decided, they gave me an option, whether what do I want to do, either to manage it or to go through brachytherapy and all the options they have. But being I have some friends who are doctors, they said in blacks, the best way is to do radical prostatectomy. That is removing the prostate. It doesn't matter, I'm already 65, so I'm not having any baby anymore. So I decided there and then, I know the pros and cons, you either die or you live. And well, the operation that was supposed to take about 2 hours went other side until about 5 hours. In fact, my wife, who works in the same hospital, could not even visit, could not even see me because it was a serious situation. Well, we thank God, here I'm still alive. 2016, April 25th, and 4 years on, and I'm happy I'm alive.
That's good news. At that point in time when you heard the news, did you think that was it, like a death sentence? Because I remember you saying during the first interview we had that you started going on cruise with, with the rest of the family. Did you think that was it for you then?
Well, there's nobody there. When your brother has already died of it, and your own PSA keeps going up, definitely that's a death sentence. Me, I love to enjoy myself. Meanwhile, before the operation, I kept enjoying myself. I had no option. You have to be happy. You have to keep happy. Everything in you has to keep happy. And then, well, my wife actually, supported me a lot, being a pharmacist. And I was given some drugs. We can't mention it because we're online, which kept it at bay before the operation. Right. And it was better managed, and NHS, I thank them very much. Very good work.
That's good. Well, one last question I have for you, Ms. Emiola, and I could remember you saying at that time that, oh my goodness, what's going to happen to my sexual life? So were you thinking of that's it, nothing is going to happen, end of?
Well, to be candid, sex is actually out of the window. Because you are playing with death. It's either you die or you sex. Which one do you take? And then they tell you, okay, your libido will be down. You might not be able to make love. Number one, you are carrying a wound. Definitely your wife will understand because it's radical prostatectomy. You are carrying the wound 10 months, 6 months, and all. I'm sure sex will not be on your mind. In fact, you will not feel like it. And I'm sure if you have a good partner, she will rather have you live than sex.
That's right.
And there are other ways you can do sex. Anyway, it doesn't mean you have to use your tool. But meanwhile, it's not the best of options to be thinking about.
Thank you so much for sharing that with us. The next person I'm going to introduce to everyone to talk briefly for a few minutes. This person is actually a liaison psychiatrist with the NHS. He holds postgraduate qualification in medical law and ethics. He's a psychiatrist. And you wonder why. Why did I bring a psychiatrist here? And I'll tell you. The person is Dr. Adeomi Ogunsheye. Dr. Adeomi, tell me, what's the role of a psychiatrist?
Can you hear me now?
Yes, we can hear you.
Okay. speaking frankly, there wouldn't be.
Touch your webcam. Okay, now we can see you. Yes.
Yeah, speaking frankly, there wouldn't be much role,
Yeah.
or there shouldn't be much role for a psychiatrist
Right.
in all of this. More importantly, I would say maybe, and I know you have somebody coming on, probably
Yeah,
better.
I have a reason for asking you the question as a
But
psychiatrist.
the reason,
Yeah.
I agree with you. But I mean, what one would look at, not to take the thunder out of the next speaker, is that in this sort of situation, you are dealing with a situation where you have, I mean, let's dissect the matter. We're talking prostate cancer.
Right.
Now, there are those things attributable to prostate itself.
Right.
And there are those things attributable to the word, the fear of that word itself,
Right.
the cancer. Then there's also the relational side of it,
Right.
which we have heard from two examples here, where the women in their lives have all been supportive. And I like because one of the things.
Can I signpost you, Dr. Busheye? Somebody comes to you, let me create a scenario.
Yes.
Somebody comes to you and they say they are depressed. They are talking. But because of our culture, the culture of silence, they keep quiet and they're, thinking about it. I mean, we've had two men talk about it. They are probably depressed at some point in time, which is natural, being human beings. So would you at that point in time think, is he having a mental breakdown or what? That's the question.
Well, sometimes by the time you take very good history,
right,
and you listen for what may also be happening in the person's life,
right,
like their past medical history, ongoing treatment,
right,
what's going on in their lives,
right.
You will be able to identify. I mean, two things drive issues. It's anxiety and fear.
Right.
So where there's anxiety, where there's fear, because don't forget, even without cancer, without prostate issues, anxiety and fear can have effects on people's libido, can have effects on the physical aspect, sexual performance. It can interfere. You see, when the erection in a man is as a result of vascular changes, where blood is pumped into certain parts, and and the penis becomes erect.
Yes.
But anxiety and fear can interfere psychologically.
Right.
Apart from that, we heard from two women, from a woman, from a lady, and from another gentleman who attested to the fact that they have other halves who are helpful and who understand and who value their lives.
Yes.
So that's taking away one great burden, the fear of abandonment.
Right, right.
You see, when a man cannot do the in the other room, there's always that fear of abandonment. There's always that negative self-image. Because unfortunately, a lot of us, it's like when we were in the showers in primary school, secondary school, it's natural. You are comparing sizes and you are comparing, stories and stuff like that. Now, so what you have is that somebody may develop a depressive view of their relationship. There's that fear of abandonment. There's the fear of death. There's the fear of death. Don't forget, I mean, Mr. Emiola said it, that when you feel that your life itself may be taken away from you, having sex becomes secondary. So these are the things, the anxiety and the fear. But what you then find out is that there's a lot of role for psychological interventions. There's a lot of role for if there is depression. If there's depression, if the anxiety and fear have led to what I would term clinical depression, obviously that has to be treated separately.
Right.
In treating it, you then will have to make sure that you are giving medications that will not interfere with whatever other treatments they are having. Of course, there's a role for psychology, not to go too much into it. So at that point, I think I will, Yeah.
You see, we don't want to create any fear here. The reason why I brought you on is that somebody actually said to me that she was trying to encourage the husband to
Yes.
go for counseling. And to some African men, so you think I'm mad. And then she said that she was not insisting that by force, but she was insisting that based on his own health, for his own good. So to him, it was like she was more or less insinuating that he was mad because he was getting depressed and he couldn't tell anybody about it. Don't forget a culture of silence and to go out there. Okay, what even, just like what Mr. Emiola said, the brother died. And when you ask in Africa, what was the cause of the death? Oh, is death. What happened to the person is death. You know the way we talk. But if it's our Caucasian cousins, they will tell you, oh, on the death certificate, this is what we heard. And then people will go for a series of tests. Maybe it's something in the family. So going back, a lot of people would think at times that, oh, it means that person has a psychiatric problem. And that's why I brought you on to
Yes.
see that this is not a psychiatric problem, and you're
No, it
quite
isn't.
right, is a psychological issue
It
to
isn't.
resolve, which which involves counseling. Yes.
It isn't. What's important is to say something here.
Yes.
You see, you having this program is actually what we need. That's where education comes into the matter, isn't it?
Yes.
Now you are reaching out to people with this program. People are getting educated. We are sharing it. And if we have more of this, education is key. Because you see, what we do is that in our community, there's a lot of stigma. We attach stigma to almost everything.
Yeah.
I mean, I've read about people being stigmatized for surviving the COVID-19 illness.
Yeah.
So we almost attach stigma to everything. And stigma is actually driven by ignorance. Stigma is also punishing a sufferer a second time. Stigma is also not reaching out in a way that could be facilitatory to a person's recovery. So I think the name of the game is education, education, education. And thank God for programs like yours, which will help to, further educate the populace about it.
Okay. One final question I have for you. As a medical professional and a member of a men's group in your local church, what do you think it would be the appropriate approach to actually educate the men?
I always say that I've done a few programs in recent years on mental health awareness in churches. And you probably may not be aware of this, but you're actually having this program during the Mental Health Awareness Week in the United Kingdom. I always say it's about following the 5 Ps. 5 Ps. And it goes for everything. It goes for whether the person is depressed, whether the person is suffering from anything, whether it's prostate, whether it's cancer or whatever. I always encourage people to do 5 things. They always start with P. The first is to be present. Be present with the person, go to see them, talk to them. The second is to be practical. Because a person who is going through things, a person who's harboring fears as to their survival, as to their life, sometimes there are things they needed to do that they have abandoned or they have neglected to do. Practical things, be helpful to them. So I always say be present, be practical. If they are the praying type, pray with them. And I also say be protective. Being protective means to assure them of confidentiality. Now, if you're my friend, and I think that by talking to you, my story is going to be all over the place tomorrow, I won't talk to you. So you have to, we have to consciously assure people that we are protective of them. And that, look, this is about this is about that, and this is what it's about. I mean, again, I will go back to what Mrs. Russell said about when she said that she said I was there from beginning to the end. You know, that just encapsulates all my P's. So to be present, to be practical, to pray with them, to be protective. And I think the last one is it's just flown out now. Anyway.
Anyway, thank you so much for that.
No, it's about assuring people of confidentiality, being protective, and to be personal.
And to be
what
personal.
I mean by being personal
Yes.
is that when you are with the individual, it's not the time to do Facebook. It's not the time to be answering messages on WhatsApp and sharing some stupid video and stuff like that. You know, show the person. I mean, if I was sitting with somebody in a clinic, for instance, if you came to see me in a clinic, and whilst you are talking to me, I'm responding to text messages on my phone. Immediately I have lost you, isn't it? You probably, if you know your rights, you probably will put in a complaint immediately.
Right.
So it's about being practical, being present, being protective, praying with them, and being personal. Okay. So if you are not going to be prepared to sacrifice those few minutes to listen to the person, don't bother, because you may actually do more damage.
Right. So in a way, we could also say that it could be part of one of the responsibility of the faith organization to discuss things like this in men's group.
Yes. In fact, a faith organization that doesn't go for things like this, to my mind, is not a faith organization. Okay. Is not one that cares for its people. Okay. The first place, I mean, I always say to people, what is your church? Yeah. Is your church a hospital? Yeah. For the infirm, or is it just a hotel? So I think the church is a place where we go to seek help. In fact, do you know that under the Mental Health Act, for instance, there is something about the police if they pick somebody up in the street who they think requires help. Yeah. And the law defines certain places as places of safety. Right. Church buildings are actually defined as places of safety.
All right. Thank you so much, Dr. Ogushaye. The next person I'm going to call on is actually a psychologist. She's the founder and director of Rollers Emotional Support and Therapy Service in Nigeria. She's a counseling psychologist and therapist, KPI Emotional Intelligence Certified Professional, and she was in the UK here for a number of years and worked with the Terence Higgins Trust as African Emotional Support. Please join me in welcoming Dr. Fola Rogers-Saliu. Dr. Rogers.
Yes, please.
Welcome. What type of counseling do you offer the men in Nigeria?
Maybe I should just say, what is the point? Dr. Ogushaye has given us the 5 P's, and that's what we'll be using. That's just a joke. Anyway.
Okay. Yeah. Given the culture, what type of counseling is it? When you're counseling the men, do you bring in their partners as well, or is it on a one-to-one? Because I'm sure there are times, I mean, Mr. and Mrs. Russell, they're a classic example whereby you just need somebody to support you going through that journey. So how do you offer the counseling service to them?
To start with, I would normally not say counseling, just because of some of what Dr. Ogushaye said, the stigma attached to almost everything and all of that. And even though we work with counseling skills, we do provide information and we do provide information through signposting and giving resources. We also do some kind of education, some form of mini training and all of that. But because of the stigma, especially that these men would not want to turn up, even women, because of the idea of what counseling is.
Yes.
And we moved again from Terence Higgins Trust to change it to emotional support.
Right.
So it is that kind of flexible service that we operate. And in our clinic, what I look into is to make sure that before we get to that point of confidentiality that Dr. Ogunseyi said, how do we start? The few I have had, we have always had problems having face-to-face intervention. It's always on the phone. We go on with that to support in that manner until that sense of trust and confidentiality is created. Then they can come forward, and now we can now, explore what the sexual concerns are. Now, with emotional support, what I do, because of the emotional intelligence specialism, is I have designed it in a way that we make use of the 5 components of the emotional intelligence. The idea is, it is about themselves and relationship. So we put that into consideration, and we kind of use the 5 components to build a model for therapy.
Right.
What are the 5 models? Self-awareness, self-recognition. Self-awareness is about understanding themselves and also their emotions and how that would affect the other people. And you're talking about anxiety, you're talking about depression and other things. What will be the hallmark of this is to develop self-confidence in them. So basically, we put those things to develop some coping skills in our clients.
Yeah.
Apart from self-awareness, we also have self-recognition, which is about being in control of those destructive impulses and moods that, from depressive moods and all of that. Motivation is another component that we really dwell on. We know that from what the 2 doctors had explained, there is pain, there is fatigue, because they have lost their strength and energy, maybe because of treatment, maybe because of medication, and also there is this fear of even the disease progressing. You have that fear at all times. We look at encouraging them to keep going, to think positively, to keep, to make sure that they are persistent in what they are doing. We support them. Now, what will be the hallmark to that? Optimism, and then to drive them to achieving a lot in terms of their relationship. Empathy is another one. Then the social skill. About empathy, as much as you want people to empathize with you, you also should know how you're going to relate with people, how you are going to treat people according to their emotional reaction, especially with the spouse, the wife, and the husband. The social skills is very, very important. Imagine someone who has been previously active and independent, now has to depend on family. Now is very apprehensive of, oh, my siblings, I don't want them to know. Even some of them will come up for this counseling. They are not talking about it to their wives at all. They are not looking at it. And there is a major issue, this libido thing, loss of libido.
Yeah.
I'm happy you have explored that with all the speakers today, and they have mentioned it. How do we, look into that? And that brings us to one of the very important aspects of what we do, couple counseling, because I think you also asked a question around that.
Yes.
It's one of the very interesting and stimulating aspects of our support. Now, we kind of encourage the men to bring their wives into counseling. Even though the 2 wives involved in what we have listened to in this presentation, they've been very supportive, they've been there all the time. It's not all the time the women can be there. Not because it's of their fault, but because they don't even understand what is happening. They don't know which methods to use. How do we go about it? What should I do? And then the man is there thinking, oh, well, maybe my days are numbered. What is going to happen to my wife? Who is going to, I know that even many people having this disease, they are from maybe 55 and above. We have heard Dr. Bimbola that it could be at the age of 40 or 45, but they are still active in sex. But this is something, and this is something that has happened that is disturbing the sexual, performance and all of that. Now, when we bring them in, we do different things to keep them together. One, it is important that they communicate. We do train them in communication skills, whereby, they can have some kind of open-ended discussion where, they can think and explore how best, or what are the alternatives to connect intimately.
Yes.
What do we do? How do we go about it? And these days, there are so many things around them that can be signposted to. Let me just give you a quick scenario of something that's happened. My husband's friend, I think they had a little issue around low libido and all of that. And then the man just decided that, okay, what I would do to my wife is to take her out to somewhere. Where did they go to? He told the wife, we are going to somewhere in the city to a shop. They got there, and to the utmost surprise of the lady, it was a sex toy shop.
Right.
And then the woman was looking at, this is an African woman. What are we doing here? What is happening? And that was the only way he could communicate the necessity, the awareness, the trend in how they can pleasure each other, apart from just having sex. What was amazing to the lady was that majority of the people who came into that shop that day were blacks. This was in England. They were black people. So you can look at that. You want to talk about issues like this. Sometimes even in group sessions, we do try to encourage them to, share this kind of experiences in group sessions. Then the most important thing is for the two to agree on alternatives way of pleasuring each other.
Right.
I have something, a poster that I'm hoping to put on in my practice. There was, these days of WhatsApp and people sending different things. There is this particular one that I got that was very interesting and amazing. The two ladies, a lady and the husband hugging. They're very elderly, probably in their 60s. And there's this, they were lying down on the bed, and there's this heart symbol, the red heart symbol, placed next to them. And then there is this caption, which talks about what they are thinking. Saying, we think we want sex. This is what is on that on the poster. We think we want sex. It's not only about sex. It's intimacy we want. To be touched, to be looked at, to be admired, to be smiled at, laugh with somebody, feel safe, feel like someone is really, got you. That is what we crave. Now, imagine when two people come in, couples, into my office, and they have seen that. I'm sure it will douse the tension, right? It will make them think, oh, life is there after all. One of the speakers said that, well, there are ways by which you can pleasure each other, and I'm happy the awareness is growing now.
Can I just cut in there, Dr. Rodo?
Yes.
Would you make suggestions at all for them to seek other ways of having sexual activity as part of your counseling session?
Yes, please. Yes. Because this is the essence of creating awareness. This is the essence of letting people know that it doesn't just end there. Just as the doctor would assure the patient that, oh, this is not a death sentence after all. You have options of treatment and all of that. It is also one of the things that we do. And I tell you, the rate at which the social media is affecting people and relationships. Sometimes you think you don't want to look at this for religious reasons. I've had friends who will say, no, I won't have that on my platform. I realize that even on platforms like the estate platform, you have people sharing things like this one that I've just told you. Actually, I got it from a platform like that. You have people sharing, about things around sex, things around how two people can pleasure themselves without actually using something. It could even be, some kind of oral thing, You don't need to use anything, because I know one of my clients said, oh, my husband is very upset about me using toys and all of this. He feels dejected, he feels this, he feels, that's the end of my life and all of that. In that case, we could explore options. Options that would not necessarily mean that they are going to use sex toys. But it is important that the two of them will come together and see how they can connect.
Yes.
Intimately. Yes.
Yeah. Thank you so much for that. I mean, that's actually very insightful. So, which means we just need to broaden our mindset. We also need to constantly renew our mindsets on some same things. Because I do realize, of course, as we know, in Africa, the way we are, the culture of silence, and then, you're bringing in sex toys. Because the other day I was reading so many things about shops like that opening up in Nigeria. And so it would help men going through situations like this. However, I have a question for the two doctors there, Professor Frank and Dr. Abolariwa. The thing is, when somebody has gone through treatment and everything, do they regain their sexual prowess again? Do they regain it?
They can do. Right. They can do. It depends on what treatments they've been through.
Right.
And it depends on what the level of functioning was beforehand.
Right.
So, so for example, if a man has been fully potent beforehand,
right,
and he has what we call a nerve-sparing radical prostatectomy. In other words, the nerves that give you erections are purposely preserved and not removed as part of the operation. Then there's a high chance that he will be able to have penetrative intercourse as beforehand.
Right, because I think that's also another reason why some people will shy away from going for the operation. There was a situation where I knew of a friend, a male friend, who started developing breasts. And I just made a joke of it. I didn't know he was going through any treatment. And he said, I'd rather grow breasts and have a long life instead of dying. So would you say that's one of the effects of taking medication, or it differs?
Yeah, so some of the tablets and indeed injections that we use to control prostate cancer do have that side effect.
Right.
There are other side effects, such as hot flushes, such as weight gain, reduction in libido, reduction in the erection's ability.
Right.
So growing breasts is one of the side effects. But even then, there are ways around that. There are other tablets that can counteract that.
Right.
And also, it's possible before starting on one of these drugs to have a small dose of radiation to your breast tissue, which will stop your breast growing if you go onto these medications.
Okay. Dr. Abolariwa, I have a question for you here. Would you, if somebody were to come into to see you and say that, well, I don't really want to receive treatment, I'd rather go for herbal remedies, do you put them off?
No, we still leave the doors open. Right. Because there's usually the phase where the patient doesn't want to accept his diagnosis.
Right.
And acceptance is key in getting the patients to cooperate with treatment. Right. So at that phase, we try to educate them and explain to them. I said at the beginning that communication is key.
Right.
And for prostate cancer, it's actually a family diagnosis. Most of the men that are diagnosed with prostate cancer may be in their elderly age group, probably retired.
Yes.
So their cost of care may be borne by the children also.
Right.
So you get everybody together. You explain to them. The man may refuse to accept his diagnosis, but the children may be able to talk to him and the wife when they get home.
Right.
So we try as much as possible to get them to cooperate. In the instance where they insist that they want to go herbal, we usually would assume that there's somebody else they're speaking to.
Right.
Maybe a pastor or something else. And a lot of men speak with each other, maybe at the clubs or wherever they meet.
Yes.
They assume that the benign prostate enlargement of another patient is not different from what they have. So they mix up a lot of things. We try to give them as much information as possible, but when they insist, we make them know the implication. We still keep the doors open. They may come back when the disease is advanced. And then sometimes you want to ask, at what stage did you diagnose this patient? Was it when you could do something to achieve a cure? Or was it at a stage where it was already locally advanced or metastatic? If it is any of those cases, what you're just trying to achieve is palliative. You know, you're not achieving a cure. So in such a case, if the man needs a break to go and maybe try his herbal options, no problem. But if it is an early disease where you have a chance for cure, we are usually more aggressive in explaining to the patient the implication of breaking his choice for therapy. Because we notice that most of the patients, we say watchful waiting, check PSAs regularly and see whether he could do without medication. They usually progress. So once we get a patient, because compliance is a problem in Nigeria, we want to offer treatment as early as possible. And most of these patients also have medical comorbidities. So you will hear somebody not managing his antihypertensives properly. Would this person come back for his cancer treatment, especially with the sequelae of all the side effects like erectile dysfunction, you know, or early andropause that you tilt the patient to on account of the hormonal drugs that they take? So if somebody is not even compliant to these diabetic medications or hypertensive, do you expect him to take this that will actually affect the quality of his life?
Just one last question for you there, Dr. Abolariwa. Would you say that infertility is a side effect, is as a result of getting prostate cancer?
No, I will not say that. I don't
So
think there's
after having prostate cancer, the person can still have children?
Oh, no. It's very unlikely. Very unlikely, except the patient. You know, at the beginning, you need to ask the patient, do you desire more children? It's a very important question. You know, everybody just assumes you want to treat cancer. What is the quality of life the patient wants? He may have a younger wife that is interested in having children. We shouldn't assume because he's 70 years old, he doesn't want more children. So we want to ask him that. And then we can ask him to have sperm banking. At that age, he may have a very, very low fertility potential anyway. So we come out to the fact. It's not as if your seminal fluid probably has enough, you know, sperm cells, or maybe he's azoospermic, no sperm cells. So we need to assess his fertility status. And if he's interested, maybe sperm banking, you know. But once he started treatment, either androgen, that's testosterone withdrawal, or he's had radiation, or maybe radical prostatectomy, it's unlikely that his fertility potential will still be the same. So these are questions you asked prior to treatment.
Okay, thank you so much, Professor Frank and Dr. Abolariwa. Now we're talking about educating ourselves and creating awareness. How do we bring other people to understand what prostate cancer is all about? My last speaker is actually a volunteer for Prostate Cancer UK, who has worked extensively for a number of years with them. Jason's role is to provide education, especially for the Black community. So please welcome Jason Hales. Jason is from the Afro-Caribbean community. Jason, briefly tell us, how did you become involved with Prostate Cancer UK?
Hi, first of all, good evening, everybody. So my day job is I'm an insurance salesperson, a life assurance salesperson. I had a Black couple come to me and wanted to do life assurance. They had 4 children. And often is the case, the ladies are very good. They get on this thing, they sign their paperwork and they get it done very easily. But some of the men, you know, they're not so willing sometimes to get their life assurance done. So the wife got hers done and the husband said, let me think about it and I'll come back to you. Some months passed, I gave him a nudge and he said, no, I'm still thinking about it. So I left him alone. A few months more passed and I got a call from his wife. And she said to me, Jason, how quick can I get this insurance policy in place? And I said, why? What's happened? Why the sudden rush to get her husband's policy in place? And she said, he's been diagnosed with prostate cancer. So having that knowledge and information, I had to see if there was any company that would even consider him for life assurance. Although for him it was at stage 1, I think it was mentioned earlier on by one of your guests about the fact that even if it's low grade and it's just been spotted and it's very small, it might mean that you don't have any medication or think further. They might just watch and wait to see what's going to happen for a certain period of time.
Right.
So even though he was at that stage, I was unable to be able to get him any life insurance at all. And that kind of process, I had to go through understanding what prostate cancer was. And I found out about the fact that me as a Black man had a higher risk. I was in my 40s at the time, and I found out that as a Black person from the age of 45, you're a higher risk as opposed to our Caucasian partners who are at 50. Yeah. So, and also another risk of cancer is obesity. And I'm a big guy and I like a lot of food. So I noticed that I ticked many of the boxes for cancer. And that made me want to tell the story to as many people as I can, because it wasn't something even me in my 40s had heard much about, especially in the Black community. And then when I spoke to prostate cancer, they happened to be putting together a team that was called a campaign called Stronger, Knowing More. And that was about raising awareness in the Black community. So I go out and I do presentations, I do awareness talks in the Black community to try and tell people about signs, symptoms, what they should look out for, what tests that they should do, and their rights in getting a PSA test, and the fact that there's help out there for them to speak to.
Do you think that women should also be trained as prostate cancer champions, just like we have some men involved in anti-FGM campaigns?
Absolutely, because when I do these presentations, like 9 times out of 10, the person that's asked somebody to come in from prostate cancer to deliver a presentation, 9 times out of 10 is women. It's women that have been in the HR department or health and safety department, and they're doing different awareness campaigns, right?
Right.
Most of the time, those women don't come to the presentation, but they should. So whenever we're asked to do a presentation, we always ask that people signpost not only to the men, but to the ladies as well.
Yeah.
Because as you mentioned at the opening, they have fathers, they have brothers, they have sons, they have cousins. They've all got men in their lives, and it is the women that save us men's lives, because it's the women that spot the difference in the fact that we're going toilet too often, or the fact that we may be dribbling once we've gone to the toilet, or the changes in our body. They actually notice before we do sometimes. And they're the ones that say, you need to go and speak to the doctor. You need to go and speak to your GP. So by having those people on board as volunteers, it strengthens us even more. You know, some of the female volunteers we've got on board have been people that their fathers who have been diagnosed and possibly died from prostate cancer. So it's about relating your story. I think most people, when they take action against things, it's hearing different people's stories. Right. So when they can go out there and tell their story about their father or brother that had prostate cancer, who didn't share the information, or as one of your doctors said, came far too late because they didn't understand signs and symptoms. It's great having women in our lives that can help educate us men and get us men to get our checks done.
All right. Thank you very much for that, Jason. I just want to ask another question, and that will be to Professor Frank. Could you say, Professor Frank, for example, if somebody were to go through this, and how do you convince them that, look, Or is there a situation whereby you would say, change your diet? This is what you can do to prevent prostate cancer. Is there something like that? Because this is an educational platform. Maybe some people are listening, they don't even have prostate cancer. They're hearing about this, they've come, they want to be educated. But at the same time, what can they do to prevent themselves from developing prostate cancer?
As my colleague said earlier, the main risk factors are things that you can't change, like your ethnicity or your age or your family history.
Yeah.
But we think there are things that you may be able to do that may help. I use the word may because we don't have the evidence base for it.
Right.
But as Jason said, keeping your weight down. I mean, obesity is a risk factor for prostate cancer.
Right.
And so we advise men who are interested in something that may be able to help them to keep their weight down.
Right.
We advise them to exercise regularly, which also helps keep the weight down.
Right.
And a diet that's rich in vegetables. So we advise vegetables, especially green vegetables. We advise broccoli. We advise cabbage. We advise tomato, pomegranate, Brazil nuts, and less red meat and less salt.
Right.
And so, in fact, these are the things that we advise men who have got prostate cancer and who are going through treatment. A lot of the men will say to us, what can we do for ourselves? And indeed, Prostate Cancer UK has a very good dietary booklet in terms of what you can do for yourself.
Right.
So going a step back, I think if we're advising younger men to try and reduce their risk, then it would be that kind of dietary advice. So less meat and more vegetables and lots of exercise. And also, there's a school of thought that's about the importance of vitamin D. So there's growing evidence that having a good vitamin D level on board may well be protective. Again, the evidence base is still growing, but vitamin D may be protective against prostate cancer. We've heard a lot in the media recently about the role of vitamin D in terms of COVID.
Yes.
Because vitamin D is known to be protective against cancers, and it's known to be protective against respiratory viruses. So one of the things that we say to young men is to, in fact, all men, is to get themselves out in the sun.
Yes.
And get that sunlight onto the skin. And if that's not possible, then take vitamin D supplementation. So that's the advice I give young men who want to try and do something. Vitamin D, exercise, keep your weight down, and pay attention to your diet. And less junk food.
Thank you. What about Dr. Abolariwa from the African perspective, or in Nigeria to be specific? Any type of food, or Professor Frank is talking about broccoli, and I'm sure majority of Nigerians don't eat broccoli. So, what are the type of foods that you would want us to focus on?
Actually, most of Nigerians don't eat fresh vegetables. We cook everything. When we tell my patients tomatoes, they're like, oh, well, we take tomatoes a lot. We blend it, we boil it, we cook it and make stew. And I'm like, no, the fresh ones. So what we usually tell them is fresh foods like maybe okra, ewedu, and all leafy vegetables. Don't cook it for too long and all. And then for those that have prostate cancers, we deliberately tell them to avoid anything folic acid. Because most of our elderly patients are already on several multivitamins. So we tell them to bring all their drugs, and then we select those that are folic acid containing multivitamins and keep it aside and tell them not to have anything to do with folic acid, at least especially while they're on treatment.
Right.
But basically, we don't have too many definition of the vitamin content of most of our local foods because of the different ways food is prepared by different cultures and all. And that is something we're actually looking into, to be able to define vitamin content per food and cooking times. Okay. And then when we get to that point, we'll be able to give a more objective advice on what to eat and what to avoid.
Thank you very much, Dr. Bolariwa. I've been taking questions. Some of the questions I've been asking them were actually taken from the chat box. So if you have any questions, please post them in, or if you want to raise up your hand to ask the question and direct it to a particular speaker, that's fine. I have a question here in the chat box. It says, at some stage, no, what's the difference between prostate cancer and benign prostate hypertrophy? I don't know what that is. Do you want to take it, Dr. Abolariwa or Professor Frank? It doesn't matter. Whoever. What's the
I
difference?
can take it.
Okay.
I can take it.
Okay.
Now, the prostate gland is in all men. They are born with it. Women do not have prostate, and that's why we say that it's not contagious. Now, that prostate gland begins to grow in a man when he gets to the age of about 40. Prior to that time, there's some stimulation by testosterone, which is the predominant male hormone. So for every man, he would have some amount of prostate enlargement. And when that starts to happen, we call it benign prostate enlargement. Benign means it's not cancerous. It's an ordinary enlargement. And it is a cross that nearly every man would bear. The degree of enlargement does not necessarily relate to the degree of symptoms that a man will have, but most men will have prostate enlargement. Now, when we say prostate cancer, the enlargement is now cancerous. Whether it was ordinarily enlarged before and converted to a cancer, or it started as a cancer from the beginning, are two different issues. Once we say prostate cancer or carcinoma, it means that it is a cancer. What is a cancer? Abnormal growth, which has the ability to spread beyond the organ in which it started its growth from. So prostate cancer is separate from the regular enlargement that every man would face. So one is ordinary, and then the other one is a cancerous growth.
Thank you.
And that's the difference.
Thank you. I have a question here from KB. What's your question? KB?
Yes, thank you. I was trying to unmute it. I wanted to find out if somebody has any other underlying illness like diabetes or high blood pressure or any other kind of illness. How does this relate with prostate cancer? Because I'm thinking about the drugs. Maybe they might conflict with each other, or would one of them lead to the other one becoming more dangerous or something? I don't know. I just want to know.
Professor Frank, do you want to take that?
Yeah, there isn't really any relationship between those things you mentioned, like diabetes and hypertension and so on. They're not more likely to cause you to have prostate cancer, and the treatments don't really interfere with managing those conditions.
Okay, I have another question from Otumba, HOO.
He's on mute.
Yeah, he's muted.
Yes. Thank you very much. And I want to say well done to the guests. They've been doing a very good job. I appreciate them. Please keep it up. All this awareness is what is missing in our community. You know, for some reasons, maybe they don't get enough funds. So I want to say thank you very much. Now, my own question might be a little bit, I'm not going to say frivolous. Is it true that the more men have sexual intercourse, the less chances of having prostate cancer? Thank you.
That's a very good question, one that's been a matter of controversy for a great many years. The balance of research, I would have to say, does seem to suggest that the more times that you ejaculate, the lower your risk of getting prostate cancer. So I think that's what I now say to men. You know, 5 years ago I may have said something different, but you know, there's been some very, very big studies with many, many thousands of men, and I think on balance, the more times you ejaculate, which for most equates to the more sex that you have, the lower your risk of prostate cancer. So there is some truth in that.
Okay. There's a question here. Oh, just to quickly address what the statement you made earlier, Otumba, you said, you know, a lot of programs like this, maybe it's probably due to lack of funding. May I just say to you that this is actually self-funded. It's not funded by any organization. This is me running this program, which I've been doing for the past, since 2012, since 8 years, and we've covered diverse topics. So it's nothing to do with any funding.
Thank you very much. Well done. God bless you.
Thank you. The next question I have here is that define erectile dysfunction. Dr. Abimbola.
Can you hear me?
Yes, we can.
Okay. Erectile dysfunction is actually the inability of a man to achieve a good, satisfactory sexual, good, satisfactory penile tumescence that is enough to actually satisfy his partner. So he has to be able to achieve the erection, achieve turgidity. He should be able to sustain it long enough to achieve satisfactory sexual intercourse. So the definition is not just based on the man, it's also based on the satisfaction quotient of his partner. You know, and sex is in different forms. Some people could actually achieve sexual satisfaction by peeping, peeping at a naked person. But if you want to define erectile dysfunction, it has to be ability to attain, sustain penetrative sexual intercourse that is satisfactory to the partner. So there are some men that say they don't mind, but the partner is complaining. So that is actually ED.
Professor Frank, what's your view?
Very similar to that. Very similar to that. It's the definition that's used in studies on erectile dysfunction is the inability to achieve an erection and to maintain an erection satisfactory for penetrative intercourse.
Okay.
So, and the reason I say that is that when we're doing studies as to these drugs, so for example, Viagra, Cialis, and so on, the way these studies are done, they don't really take into account the satisfaction of the partner. It's simply the ability to achieve penetration, because if we're doing scientific studies, then there's so many variables if you take into account the satisfaction of the partner. So for medical studies, it's just the ability to penetrate.
Okay, thank you. I have a statement here. And for me, it will be good to hear why you are passionate about educating people on prostate cancer. Well, the thing is, I'm passionate about so many topical issues that are being kept in the dark, so to speak, that we Africans hardly talk about in the open. And as I've always said, if we keep everything to ourselves, I mean, prostate cancer is a big issue. Some people would keep quiet about it, and unfortunately, their children will go through it, and then it becomes some sort of family trend, so to speak. Because when people are supposed to talk, they don't talk about things. So it's not only prostate cancer that I'm passionate about. I've covered topics on female genital mutilation, adoption, surrogacy, human trafficking, coping with disability, menopause. We have our own issues as well as women, So it's not just one topic that I focus on. I focus on so many things that due to our culture and, traditional values, that we need to speak. We need to talk about it and seek prompt intervention, because some people die in silence. The moment they hear things like prostate cancer, they're already dead. And they don't seek they don't seek for help. They don't talk to anybody about it. For example, I'm not even sure whether there is a support group for prostate cancer. Is there one, Dr. Abimbola? Is there one in Nigeria?
I'm not aware of any public support group. There may be some private support groups, but I'm not aware of any. And that's the honest truth.
Yeah, because it's amazing. People like Mr. Emiola, he goes, I mean, he travels, he's always in Nigeria and in the UK. People like him is very open to help other people, because I remember the first time when I spoke with him, he said, I need to talk about this. I don't care. Even if it's one life I save. And I'm thinking to myself as well, whilst we're here, even if it's one life we save today as a cause of having this program, it's something, it's an achievement. So it's like going out there, let's break the culture of silence, which is prevalent within our community. Let's talk about these things openly, and let it be our individual responsibility, and also the faith organizations, let it be their responsibility as well to talk about this, to their congregation. And that's it, really. So can I take one or two more questions before we wrap up for the evening? Any more questions? Okay, I have a question from Mr. Richard Taylor there.
Yes, good evening, friends and family members, both in the UK and in Nigeria. This is not really a question. It's just to say, in my own views, I have to commend the work of Professor Chidundu, who happens to have done so much in the BME community in the UK. I have the opportunity of working or being in places that he's been delivering his experience. He's been giving out his experience, to the Black community, and his work is so appreciated, here in the UK. He's been working in Nigeria too, but like you have, for me, you have, done this, voluntarily. You've put all your resources, into it. He has done that in Nigeria, but he's not commensurate to the effort, that like Dr. Abimbola has just mentioned, that she's not aware of any activities going on, So I want to commend the effort of everybody here. I went through the surgery, having been diagnosed with prostate cancer 10 years ago. And I had a prostatectomy, radical prostatectomy, and unfortunately, the cancer came back, the residue came back. I'm still undergoing, treatment for that. So it's something that we have to create that awareness, among the men, couples that have identified it and they have been working together, to sustain their marriage is very commendable as well. So I want to say, well done to you, for me.
Oh, thank you.
And keep it going, keep the flag flying, and we will bump into each other again, in the UK or in Nigeria. We are ready to support you. I want to thank Dr. Rogers, who we happen to know very well, both here in the UK and in Nigeria, for inviting me to this. It was the email she sent to me that I responded to. So well done, everybody.
Thank you very much. Professor Frank, any closing remark or statement regarding prostate cancer? We don't want to create fears, but at the same time, we want to raise the awareness.
I think one thing that's very important is this, as you say, raising awareness. Now, if you don't know that you have a prostate gland, if you don't know that it can turn cancerous, then you wouldn't know that there's a blood test called PSA. Now, certainly in the UK and also in Nigeria, there is no national screening program. In other words, no one is going to invite you to come along and have a PSA blood test. So when we raise awareness, then men know that they can go to their GP, certainly in the UK and in Nigeria, they can go to clinics and request to have a PSA blood test. So don't wait to be invited, because no one's going to invite you. Okay. So Black men over the age of 45, get your PSA tested once a year.
Yeah. Did you hear that? From the age of 45, get your PSA test done. And for ladies even listening to us here, push your partners to go and have it, or your brothers, your sons, your male relatives, friends. Dr. Abolariwa, any closing remark?
My closing remark is that prostate cancer is not a death sentence. It's not a cancer that once you get your diagnosis, then you start thinking of, oh, I'm going to have chemotherapy, I'm going to die. No. I always tell my patients that so many things could kill a man, and a man could die with prostate cancer and not of cancer. There's life after prostate cancer diagnosis. And we need to approach prostate cancer care as a family affair and get as much support that the patient needs together with the doctors. This is a pattern that we have seen that has worked successfully with the one-on-one care. And also to encourage other people, churches, clubs, to increase their awareness. We do that a lot, give a lot of health talks to churches. I've done that to social clubs. And a lot of them have gotten some information about prostate cancer. There's a lot of misinformation around. So it is important that the right information comes out from the specialist and goes to the community. And that's what I'd like to encourage, to target churches, social clubs, before the government picks this up as a sense of duty. And then also to encourage the government to screen, particularly starting from civil servants before they spread out to the community, an annual screening for the men once they get to the age of 45.
Okay. Thank you. What about you, Jason? Closing statement?
I just wanted to say once again, thank you very much indeed for putting this together. I think the important thing is understanding your rights. I think the gentleman just mentioned it earlier on, is to go to your GP if you are having any signs and symptoms, and tell them actually that you want to get checked. Because I think in this country, sometimes they're very reluctant. They're like, we don't want to do that, or there's a cost to having the PSA test. So they're not very willing sometimes for you to go and get a test done. But I think it's something that on an annual basis, you should consider, especially if you've had brothers or your father has been diagnosed with prostate cancer. You're 2.5 times more likely that you could be diagnosed with it also. So it's really important to just get people in the habit of getting checked, even if you don't have any signs and symptoms. Understand our risk in our people and go, every couple of years, I need to get checked.
Okay, thank you. And then people can always go online to check the statistics posted by Prostate Cancer UK. And then there is a helpline there as well. Yes? Correct. What about you, Mr. Miola? What do you want us to take away today?
Like I always say, I wish we could create more awareness in Nigeria. The last time you came, we tried to do it, but we could not achieve it. Apart from the one I had in Reading, I've not had another one, apart from those government college old boys that I did in Nigeria and in Reading. But we wish we could raise more awareness. I'm in Nigeria now till about August, God willing. If we could get round, you can tell doctor whatever, if we could, stay in and create awareness, maybe for a church or any society where we could allow them to, we could sensitize them for them to go for tests, and then we will guide them through. We are alive and will still be alive for more than at 70 next July. I will still wish another 20-something years more.
Yes, of course. So it's not only the churches, the clubs in Nigeria, even over here as well, mosques, all the faith organizations. And then you mentioned something to do with schools. It could be alumni associations, all the boys' schools, to do that. So it's a way of creating awareness, raising the awareness as well, and educating people. So what about you, Dr. Rogers?
I really need to commend Ram, and I would like to encourage everyone to join hands with this type of initiative to transform the culture of silence surrounding prostate cancer, not only prostate cancer, so many things, because I'm looking at it from the point of, somebody who is supporting people emotionally, right, so that it will transform to the one of openness, knowledge, and action.
Right.
Thank you.
Thank you. What about you, Dr. Deomi?
Well, I'll just sort of echo what everybody else has said. Mm-hmm. It's about education. I mean, apart from cancer, I think there's probably no other area of human conditions that creates fear, anxiety, and is so as maligned as psychiatry. Mm-hmm. I've been to places where I've introduced myself as a psychiatrist, and I've seen people sort of move away from sitting close to me, almost like they will catch something. But we need to educate ourselves. Yeah. There is no amount of dodging the issue that will bring solution. And so it's, I commend the organizer, yourself, and everybody associated with the organization in putting this together. And then there's baby steps to take. I mean, Professor Frank mentioned, the sort of foods. Dr. Bimbola mentioned some foods. Exercise is there, regular brisk walk. If you can avoid taking the bus to the station in the morning and just walking to the station, brisk walk, tomatoes and stuff, things like that. Yeah. And I think that's the way to go. In terms of psychiatry and its role in all of this, there is nothing to fear. It's about monitoring response, because you will find out that, just as Dr. Rogers has pointed out, where there's counseling, it's about demystifying. It's about opening things up. Right. There's a biblical expression that when you know the truth will set you free, and that is what this is about. Right. So let's keep the flag flying. Thank you.
Thank you very much, Dr. Odeomi. What about you, Mr. and Mrs. Russell? Mr. Russell?
Right. I can, yes, I've just unmuted myself. I can only commend you on doing this. And I personally belong to a support group here in the hospital which treated me. Right. And we focus, and I do focus on awareness. Right. And I think the important thing to know, the UK right now, before it was predominantly breast cancer, which was the main cancer problem here. Now it has been overtaken by prostate cancer. So the resources are actually being increased. That was the last count, which I heard of. And I am very happy with that to a certain extent. In fact, I also took part in something here which is called Cancer Survivors Day, which one day of the year is actually earmarked for the survivors of this cancer, not just prostate cancer, but cancer per se. And I am happy that there is more awareness, and I am happy also to volunteer my time and efforts to promoting awareness, not only here, but in the world, also especially in Africa, and also in the Caribbean, right, with this. So I am really pleased to have been a part of this this discussion today. And it was very positive hearing the brothers and sisters also contributing to this. Thank you very much.
Thank you, Mr. Russell. So, Dr. Bolarinwa, there you go. You can actually link up with Mr. Russell and maybe form a group, because somebody just sent a message to me in the chat box saying that a WhatsApp group could be, created for this. So we'll be talking offline, obviously. What about, is Mrs. Russell still there? Maybe she has something to pass on to the ladies, or?
Unfortunately, no, she had to attend to something else.
Okay.
But I know that she's actually along the same line as myself.
Of course.
She supported me all this time.
Okay. So maybe I'll probably speak for her then, that women should be supportive of their male relatives. So the support is really needed. I mean, it's like anything else. If you're scared of something or scared of, you think it might be bad news, you need the support of someone to go with you for the test and to even encourage you to go for treatments, or, even if you're going through the treatment, somebody to hold you by the hand, that it is all right, it is okay. So I'd like to thank everybody for making this possible.